Welcome, everyone. We appreciate you spending this hour or 20 minutes of time with us as we, I think, dig into a topic that's pretty common when you think about people who are impacted by cancer. My name is Linda Bohannon, and I'm the president of the Cancer Support Community. And I'm so pleased to be joined by, first and foremost, my personal friend, Kristi Orbaugh, for this important topic. And Kristi, we're so happy to have you with us. And I know you bring a wealth of experience as an advanced nurse practitioner. You're a certified oncology nurse. You work every day with patients in the clinic who are experiencing challenges with pain management and the side effects and some of the trade-off decisions of, if I try to manage this pain, I might not feel as well as I would if I didn't, and those type of trade-offs. So we appreciate you taking some time out from your busy practice in Indianapolis, Indiana, with Community Health in the north area, which is also a part of the MD Anderson network. So first and foremost, thank you for being here, and I can't tell you how much we appreciate you.
I'm very excited to join.
Thank you. So let's jump in. The topic of today's discussion is really multi-focus. So first and foremost, pain management. And we really want to get to the broader issue of pain management, which is how do people manage and navigate through the side effects that they may experience with the use of opioids in particular. So let's start at the root of that and just share with our listeners, what are some of the strategies around pain management in general?
Well, I'll tell you the very first thing is good communication between the provider and the patient, right? When I sit down with the patient and they're having pain, I need to understand it. And I know that is so hard. You know, when you say, okay, Linda, tell me about your pain. Well, your pain hurts, right? That's how you feel. But if you can possibly tell your provider it burns, it's sharp, it's dull, it's constant, it's crampy. All of those types of adjectives really help us dial in on the type of pain management we need, at least to start with. We treat nerve pain differently than we treat bone pain. And so the more information you can share with your provider, the better able we are to care for you and manage that pain.
Okay. And so what are some of the things that you do for people? Give examples of how that might differ. So if somebody has what might be a muscle ache versus a bone pain, what's the difference in the way that you might manage those?
So let's say that someone comes to us and they have a lot of bony metastasis, or the cancer has spread to their bone, and that's really causing them this dull ache and kind of constant pain. We usually intervene with some opioids at that time. And if it's constant pain, you'll probably hear your provider say, we need to get on something long acting. The last thing we like to do is chase pain. We treat it a lot better than we chase it. So if we get someone on something long acting, you don't have those peaks and valleys. Like you take your pain medicine, oh gosh, I feel a lot better. Oh, now it's worn off and I'm in pain again. So we like to get them on something long acting. And then you can also use short acting if you have what we call breakthrough pain. Like, you know, it helps most of the time, but boy, when I get up and try to get some stuff done around the house, I feel it in my back a little more. And then you can take a short acting. And then that's opposed to, gosh, I have nerve related pain. Then we might use something more related to or directed at that, like maybe gabapentin, which is more directed at nerve pain.
Mm-hmm. So say something about just the general misperception that people have to live in pain. You know, right. I think that a lot of people feel like I just got to white knuckle through and I don't want to say anything. And, you know, so speak to that. When you have patients, what do they bring to you and how do you work them through that misperception?
You know, patients will just do better. And I tell them this all day long. Will do so much better if we manage their pain. They'll eat better, they'll sleep better, they'll enjoy life better, they'll be less cranky. I don't know about you, Linda, but if I have a headache, I'm not the most pleasant to be around. So if we're all talking about quality of life and living as long as we can, as well as we can, managing pain is way at the top of the list. Patients aren't going to get addicted. I spend a lot of my day encouraging patients to take their pain medicine on a regular basis and trying to alleviate fears that they will become addicted. This is a different type of thing. They have documented pain. And if we can control their pain and they take pain medicine on a regular basis, really, sometimes they end up taking a lot less pain medicine than if we have to chase it because they don't take it regularly enough.
That's really interesting. And you might want to explain that a little bit, because I don't know if that's so intuitive to people, that by communicating well and trying to really pinpoint the source and get on the appropriate type of treatment, you could potentially be taking less medication than if you don't.
Right. So Linda, just for a second, say you're my patient, okay? And you're very hesitant to take your pain medicine like it's prescribed. You know, you, for whatever reason, you know, you have your own personal concerns. So then what will happen is, instead of taking one every 4 hours, or if you're on a long acting one every 12 hours, consistently, you hurt and that pain increases. As that pain increases, you get more tense, you get muscle, you know, your muscles are all tensed up. The pain even increases more. And then you have to take 2 pills instead of 1. They don't last 4 to 6 hours then, so you're wanting to take more. So you end up having to take more to get you your pain level that has now skyrocketed to an 8 or a 9 down to where it's more tolerable.
Yeah, that makes a lot of sense to me. And I also love how you describe how pain really impacts everything that surrounds you, right? The way you eat, as you said. I think about just even the way you breathe, you know, and, you know, being able to just have less labored breathing and relaxing and those sort of things, and your interpersonal relationships and depression and anxiety, you know, and all of that.
On Monday, Linda, that said to me, just such a precious patient, and said, now I'm okay as long as I sit in my chair and don't move. That's the last thing we want. That's right. And especially in 2020, I tell you, we have had such breakthroughs with oncology. Even if we can't cure your cancer, so many cancers are turned into a chronic disease that we manage over years. I don't want my patients sitting in a chair for years so they don't hurt. I want to manage their pain so they get up and get busy with living.
Right. And that goes back to living with cancer.
Right. Exactly.
Yeah. Yes. And I know that you and I had shared a message earlier this week that you have a number of patients who, you know, for years they're in the workforce, that they sometimes can't, you know, do some fun things because their work life gets in the way.
That's exactly right. You had sent me an invitation for patients that would fit in a particular category, and I had reached out to a few of them, and they have stage 4 disease, and they couldn't take the day off work. That's exactly, one works for UPS, and he looked at me and laughed, and he said, do you not know what season it is? And then the other one is a manager of maintenance at an entire apartment complex. And he's like, I can't, you know, they go to work every single day. And they just looked at me like I was crazy that they could stay home. They're too busy living.
Yeah, I love that. I love that. And to your point, it's very different than when you and I first started working together as young nurses.
Yes, it is. We didn't have those patients that could have chronic disease. And so I love where we're at right now in oncology. So exciting. Head spinning if you're a provider and you're trying to keep up with it all, but that's an okay problem to have.
That's right. We actually refer to you as heroes, by the way, not just providers.
Can you share that with my children?
Well, you have one that is a hero, so
Yeah, I do.
also a nurse.
Yes.
Well, actually, two, because one is a teacher, so they
Right,
both fit into that category. So let's talk about some of the side effects that people may experience if they're being treated with opioids that might also deter them from taking their medications as they could to get the maximum benefit from that. Let's start with nausea. I think that's one that's pretty common.
Right.
And how do you sort of manage through that as a potential side effect?
Opioids or pain medicines can cause some nausea, but we have excellent anti-nausea drugs, right? So again, if you're my patient and you're struggling with some nausea, you got to let me know that. So we can sit down together and figure out when you're taking your pain medicine and see if we can't find a regimen or a recipe, whatever you want to say, where you'll take your anti-nausea medicine, maybe 30 minutes before, so it has time to kick in, and then you take your pain medicine and you get that anti-nausea on board. There's also pain medicines that aren't taken by mouth, that are put on by patches if nausea is a really big problem. But even though, we laughed about my children a little bit ago, but I tell my kids I can read minds, but I tell my patients I can't. And so if I put you on a pain medicine and I don't hear from you, I'm going to assume it's going okay. So I want you to reach out to me and say, hey, this isn't going okay. I've got some nausea. And then I've got tools to help work you through that.
Right. The other one is drowsiness. They feel like they may not want to be sleepy or tired and be more alert.
Right. And our goal in pain management is not to put people to sleep, right? We want to be up, we want to be enjoying our family, our life, whatever all that includes. Anytime you start someone on pain medicine, I'm going to be honest, for the first 48, 72 hours, you may have some drowsiness, especially if, again, I'm going to use you as my patient. If you've had a lot of pain and you haven't been sleeping well, you haven't been resting well, you haven't been relaxing well, and now suddenly we start relieving your pain, your body's going to relax a bit. But really, if you will just hang with it through that 48, 72 hours, that drowsiness really does tend to go away. Now, let's say it's unusual, but let's say yours doesn't. Again, get a hold of your provider and say, I like the pain control that I have, but I don't like the drowsiness. Is there anything we can do to adjust this? And, I use stimulants in my practice as well, to help give people more energy. And so there's lots of options.
So we have a question that came in from a listener, and while we're on the idea of drowsiness, this listener is actually asking about incorporating sleep management with pain management. And this listener talks about using pain pills to sleep. Is that the right approach, or should that be a different conversation?
It depends on why they're not sleeping, right? Are they not sleeping because of the pain? Or are they not sleeping because, gosh, you turn the lights out, the house gets quiet, and then that mind starts going on and on and on. I think all humans do that a lot, don't we? So it depends on why. No, we don't want you to use your pain medicine as a sleeping pill unless you're not sleeping because of pain. But if insomnia is a problem, if you're, you feel like you're just not able to turn that mind off, or your anxiety, understandably, it is quite bothersome, that's another thing. Reach out. I tell you what, we have a whole counseling. I'm so blessed where I work. We have a whole counseling team that help people with sleep hygiene and knowing when to go to sleep, and just good tips. And we do use sleeping pills if it's appropriate.
Uh-huh. Okay. So let's talk about a side effect that my last clinical role, I was a home hospice nurse. And so it's been a long time, and we used to deal with this a lot in that particular setting. And I don't know that patients are as attuned to this as a potential side effect from opioids. But as a nurse, when they come to you with a complaint, you can certainly put that piece together. And I do think that this is a place where communication is important. Constipation.
Oh,
So
gee.
people who are on opioids have constipation. So can you sort of talk through that a little bit, just in the spirit of raising awareness?
Right.
What do you want people to think about? How should they communicate with you effectively? And then, most importantly, what can you do about that?
Right. Well, first of all, I think it's important that they kind of understand why it can cause constipation, right? It can kind of just slow that bowel down. So as our waste products move through our intestinal system, the slower they move, the drier they get, and pain medicine can make it move through our system slower.
Mm-hmm.
So we encourage patients to get on a bowel regimen right away. We usually start people with stool softeners. Now, patients don't ever want to overdose on stool softeners or overdose on laxatives, but let's be honest, really the only thing that can happen bad if you overdose on one of those is you may go the other way, right? You may have a little loose stool for a while, but we try to help them get on a regimen of taking stool softeners in the morning and the evening, increasing their fiber if they can, all of those types of things. Sometimes we do have to add a laxative, and we help work through that. But boy, I tell you what, I would much rather have my pain controlled and take a laxative and a stool softener on a regular basis than have my bowels working freely normally and then have pain.
Right. So I want to sort of wrap our conversation, and I do have some additional questions, but for just a time being, because I do think that this is really important in what I'm hearing from you, there's a theme that I hear you talk about, whether it's reporting your pain, whether it's talking about constipation, whether it's talking about nausea. What I'm hearing you talk about, the importance of communication,
Mm-hmm.
and early and often, right? Details, that it's important for the patients to share details with you, and that in all of these scenarios, careful planning alongside you can help mitigate some of the issues that we're talking about.
Absolutely. First and foremost, I want to stress to patients that might be listening is they know their body better than anyone else in the world. Mm-hmm. Doesn't matter what schooling you've gone to, what schooling I've gone to, your oncologist, whatever, that patient knows their body. And so they're in charge. With that said, I just want to really impress on them that people that work at their clinic are on their team. They want them to have the best life possible. They want to help control their symptoms. So if we can think of each other all on Team Linda, and know that any information they share with us, we will try to use to the best of our knowledge and mitigate any toxicity that might be arising. You have to be able to communicate with your provider. It may be your infusion nurse that you have a really, really good relationship with. It may be your home health nurse. It may be, but find someone in your clinic that's your person, and you really feel like you can say whatever you need to and have confidence that they really have your best interest at heart.
Mm-hmm. How do you get them to bring up sensitive conversations, like with constipation? How would you encourage patients to say, to tell you what's happening with them, so that you do know there's a whole now, again, to the advancement of science, there are a ton of options to give people who are experiencing this type of a side effect. How would you encourage them to reach out to you?
Well, if I'm going to start you on pain medicine, I better tell you that that's a potential side effect. So I better open that door right now. Okay. I better open it and let you know. And then as you come in, I need to be asking about that. But if I don't, hopefully because I've opened that door, you'll feel comfortable. I'm not minimizing any toxicity or how it can be difficult to maybe talk about intimate or more private issues to a provider. But I can tell you those are the things we do want to hear and are important. I do want to know about their bowel habits. I understand that can be a difficult thing to talk about, but that is something I want to talk about and be able to help them with.
Yeah. So we have Valerie, and thank you, Valerie, for joining us, and Kate as well. But Valerie specifically is asking about how we get past the stigma of having to take opioids.
I tell you what, that is a tough one, right? Because in oncology, I feel like we live in a different world. Patients that are prescribed opioids in oncology rarely have any addiction issues, rarely have any, and we're using it to treat your pain. We're using it for appropriate reasons. It's being prescribed by a provider that's understands the case, understands the cancer, understands the appropriate way to treat it. I know I have patients that just don't tell anyone they're on opioids except their close family. And that's okay. That's okay. They don't have to, that's not something anyone has to know if they feel, if they feel quiet about that or feel like that's something they want to keep to themselves. And that's okay.
I'm just taking a look at some of the questions that we have coming in, and these two are kind of related, and I want to sort of use this as an opportunity to share with people the discipline of palliative medicine. So Kate is, just talking about who sort of goes into palliative medicine, and that people who, gravitate towards that have a level of empathy and a level of emotional care for people. And perhaps it is the holistic approach. So you're not just looking at a body part, you're looking at a human being and thinking about how all of these pieces, fit together in supporting the human being. And when I think about that, I'm reading sort of the next question, which is from Fina, who is a uterine cancer stage 4 patient. And she has outlined some of the things that she's taking, but she says that she's afraid to take anything more because of addiction. So, we can't comment on your particular case, and I apologize for that. But, Kristi, maybe you could just help assure her of her opportunity to talk to her palliative care specialist, and whether that is an advanced nurse practitioner or someone else who works in her clinic, maybe just go over what those options could look like for her.
Right. There are a lot of holistic things. You're right. Relaxation, massage, acupuncture, all of that type of thing. But pain management really has a big appropriate place in palliative care. And as I said earlier, addiction really, it's hard because, right, everything we see right now on TV is don't take opioids or this happened or that happened. But that's in a whole different population. That is in a whole different population. So I would encourage any of the listeners that are having that fear, I don't want to become addicted. Know that your provider is going to work through that prevent that, if you will, or not prevent it, but that's not our concern. Addiction just really rarely happens to people that take pain medicine appropriately for pain.
Mhm.
Good managed pain patients just don't become addicted.
Mhm, mhm. Yeah, and that's been our experience too. And one of the things that I'm going to stall for a second because I want to see if any of our listeners have questions before we close here. But we do have resources on our website. So if you haven't had a chance to visit www.cancersupportcommunity.org, we have a whole suite of materials called Frankly Speaking About Cancer. And we do have a component of Frankly Speaking About Cancer that speaks to side effect management. And we do speak a little bit to nausea and vomiting and drowsiness and constipation and all of those things that you might not be comfortable asking a human, but go take a read and then come back to your team and talk to the humans about it for sure. Because as Kristi said, this is about living well with cancer. And the way in which to do that is to make sure that you take advantage of all the tools that are available to you. So Kristi, do you have any other parting words as we think about our time here today? I sort of rally back to, I'm looking down at my notes, communication, details, and planning.
Absolutely. And just having confidence that we're all on the team. We're all on the same team. We want the best for that patient, and we'll bend over backwards, do anything within our power to help make that happen. And I think that's important that we remember we're all after the same goal.
Great. Thank you. And I want to thank you for being here, Kristi Orbaugh, Advanced Nurse Practitioner with Community Health Network, a division of MD Anderson. And we are so lucky to have you in my hometown of Indianapolis, Indiana. So thank you for all you do and for joining us today. And then I just want to thank our sponsor today, Salix, for really allowing us to elevate this important conversation about opioids and in particular about constipation associated with opioid use. So I really appreciate you being here and for the information that you've shared with our listeners. And we will be back in touch with you again soon, Kristi, for another interesting topic here.
Thank you very much. It was my pleasure.
All right. Take care, everyone. Enjoy your afternoon.